So it's been a while. I apologize for that. All right, straight to it. So for this question, we have a 64-year-old man with a 10-year history of type 2 diabetes mellitus and hypertension comes to the clinic for routine follow-up. He reports progressive fatigue and decreased exercise tolerance over the past 6 months. He denies chest pain or shortness of breath at rest. Physical examination reveals conjunctival pallor. Cardiac exam shows a laterally displaced apical impulse. Laboratory studies, hemoglobin 9.1, MCV 88, serum creatinine 3.1, BUN 42, ferritin is normal. ECG shows increased QRS voltage consistent with left ventricular hypertrophy. Echocardiography shows concentric left ventricular hypertrophy with preserved ejection fraction. Which of the following mechanisms best explains the development of this patient's cardiac findings? All right, so for this, the answer is D. Reduced oxygen carrying capacity leading to compensatory myocardial remodeling. All right, so if you look at what's provided here and take it all as a big picture, so you can see that the apical impulse has been laterally displaced. So that's consistent with there being hypertrophy, left ventricular hypertrophy to be specific. If you see the type of left ventricular hypertrophy, it's concentric as opposed to eccentric, right? So that should tell you that, well, first of all, there's an issue with, it's in such a way that the heart is doing some extra work to pump, so it's not a blood volume kind of issue, all right? So there are kidney problems here. You see the elevated BUN, elevated creatinine, right? The person has a history of diabetes, so that should tell you that they're prone to CKD, right? So chronic kidney disease. Now, what happens in CKD that relates to blood in general, right? So the kidney produces EPO, right? Erythropoietin, so EPO. So in CKD, the production of EPO is reduced, okay? So if you have decreased erythropoietin, you're going to have a decrease in hemoglobin. So you're going to have a decrease in hemoglobin, right? In hemoglobin. All right, so if you have a decrease in hemoglobin, that means there isn't going to be as much oxygen carrying capacity in the blood. Now, the body is going to try and make up for this, and the way it's going to do this is by causing the heart to pump faster, to pump harder. And all of these are then going to cause remodeling in the heart. So you're going to get the hypertrophy as a result of it. So this is going to lead you to hypertrophy. Hypertrophy. Okay, specifically the concentric kind. So let's look at the other options. Increased cardiac output due to chronic hypoxemia. So this is something you really see in COPD, right? So you are going to have that increased like left ventricular hypertrophy. You're going to have that, but it's as a result of, okay, there's little oxygen coming into the blood, so you're going to have to pump harder to get that going, right? Option B, increased afterload due to systemic vasoconstriction. So this can also lead you to that concentric hypertrophy, but eventually it might actually go completely to heart failure, right? So this is the kind of mechanism you see when you have hypertension. So chronic hypertension. Okay, then option C, chronic volume overload from sodium retention, which again, CKD can lead to sodium retention, lead to fluid retention, and then it will, you just have that fluid building up, but what it's going to lead to is eccentric hypertrophy. So with this, you're going to see eccentric hypertrophy. And by the way, all this really means when we talk about eccentric versus concentric hypertrophy is what ways are the muscle fibers being added? Is it in parallel, right? Or is it like sequentially being added, right? So in eccentric, it's one after the other, while in concentric, it is parallel, all right? Then option E, direct myocardial toxicity from uremic metabolites. Now, that can actually affect the heart, right? It can cause hypertrophy, but importantly, when it comes to particularly to exams, they're looking for pericarditis here. So pericarditis. All right, so see you in the next one.